to Pediheart, Pediatric Cardiology Today. My name is Dr. Robert Pass, and I'm the host of this podcast. I'm Professor of Pediatrics at the Icahn School of Medicine here at Mount Sinai. Thank you for joining me for this 301st episode of the podcast. I hope everybody enjoyed last week's milestone episode in which we took a step back in time to speak with Dr. Phil Saul, Dr. John Triedman, and Dr. Edward Walsh about the beginnings of the famed electrophysiology program at Boston Children's Hospital, as well as the early days of radiofrequency catheter ablation for children. For those of you interested in electrophysiology, as well as the history of medicine and the history of our field, I'd certainly recommend you take a listen to last week's milestone episode, 300. As I say every week, if you'd like to get in touch with me, my email is easy to remember. It's pediheart@gmail.com. This week we move into the world of congenital heart disease, electrophysiology, and adult congenital heart disease. The title of the work we'll be reviewing is Development and Validation of a Mortality Risk Score for Repaired Tetralogy of Fallot. The first author of this work is Joshua Mayorian, and the senior authors of this work are Anne-Marie Valenti and Tal Geva. And the authors represent multiple centers throughout the world, with the first and senior authors coming to us from Boston Children's Hospital, Harvard University. When we're done reviewing this paper, Dr. Tal Geva, who's the Chief of Cardiology at Children's Hospital Boston, has graciously agreed to join us to discuss it. Therefore, let's move straight on to this important paper, and then a conversation with its senior author. This week's work begins with some comments about Tetralogy of Fallot, explaining that with advances in our care of these patients, there have been improvements in outcomes, while also reminding us that the residual hemodynamic abnormalities, which are largely related to the RV outflow tract dysfunction seen in most of these patients, does predispose these patients later in life to enhanced risks of morbidity and premature death, and how this fact means that we still need better risk stratification tools, as we have learned in a number of prior works that we've reviewed on this podcast, as well as many, many more in the literature. The authors then remind about the Indicator Registry, with Indicator standing for International Multi-Center Tetralogy of Fallot Registry, which was designed to allow for a larger cohort to study this topic. They review how this cohort has resulted in prior works in which RV hypertrophy, dysfunction, or the presence of atrial arrhythmias have been identified in studies using this database previously to be worrisome signs or independent predictors of death or sustained ventricular tachycardia. However, they explain that when these models were tested with external validation datasets, they did not perform as robustly as was initially predicted, and this fact has suggested to the authors the importance of development of larger cohorts with longer follow-up in order to develop and then importantly validate a risk stratification model for this at-risk patient group. They explain that the indicator cohort was recently updated to allow for more extended follow-up, and this has, in their view, allowed for more statistical power to address clinically important topics in this patient group. And so they explain that in the work we'll be reviewing this week, the updated indicator cohort was used to develop and then again, importantly, externally validate a novel risk score model for all-cause mortality in patients with repaired Tetralogy of Fallot, using all of the data in their database, such as both clinical and imaging biomarkers. The model allowed for risk stratification into low and high-risk groups with the goal of better informing surveillance practices and maybe even interventions on this patient group. The authors review the indicator cohort, and for those interested, as usual, I would recommend you read the paper, but there are 4 participating centers in Toronto, London, Amsterdam, and Boston, and the patients had to have repaired Tetralogy of Fallot, have a CMR after January of 2002, and finally have clinical follow-up greater than or equal to 1 year after the CMR or occurrence of the primary outcome. They review the exclusion criteria and explain that the data coordinating center for this registry was at Boston Children's Hospital, and the authors review the many data points included, and there are many things, as you would imagine, in this tetralogy database, and these include such general topics as clinical findings, CMR data, electrocardiographic findings, Holter information, surgical data, and much more. The primary outcome for this work was time to all-cause death, and the deaths were categorized as cardiac, non-cardiac, or unknown cause of death. The composite secondary outcome was a major arrhythmia, defined as time to the earliest occurrence of aborted sudden cardiac death, sustained VT, sustained atrial arrhythmias, or non-sustained VT. The development cohort included the patients from London, Amsterdam, and Boston, and the Toronto cohort, which was 21% of the total indicator cohort, were assigned to be the so-called external validation cohort, and were not included in the development cohort. But again, it's important to remember that the Toronto group is in fact part of the indicator cohort, but for this study, it was artificially separated and made the validation cohort. The authors go through the construction of the data analysis as well as the Cox multivariable model construction. The details of this fantastic analysis are in the paper on page 3 and are far beyond the confines of this podcast and this podcaster. And so I would strongly recommend that you take a look at the paper to better understand the job that these authors did in their statistical analysis. And on to the results. There are 1,808 patients in the indicator registry, but of these, 1,552 were eligible, with 84% having tetralogy with pulmonary stenosis and 16% tetralogy with pulmonary atresia. And the authors explain that roughly one-third had a palliative shunt prior to repair. The median age at repair was 2.1 years, with 47% of this cohort having had repair before 1986. In regards to the repairs, half were transannular patch repairs and 14% had an RV to PA conduit, with 58% having had a PVR at some point after their first operation. The median age at time of CMR in this work was 23 years, and atrial arrhythmias were seen in 8%, whereas non-sustained VT in 12%. Figure 1 of this work shows the breakdown of the 1,552 patients included in this work, and they demonstrate how the development cohort had 1,221 patients, in which 6.1% died, and the external validation Toronto group had 331 patients, of which 8.5% died. Overall, 6.6% experienced the primary outcome of all-cause death. Importantly, when comparing the external validation group to the algorithm development group, on average, patients were older at the age of repair, and their CMR were repaired more commonly in the earlier era, had longer follow-up time, and higher BMI, all in the Toronto group. Importantly, however, the external validation group had a lower percentage of complex tetralogy patients, meaning fewer patients with Tetralogy of Fallot with pulmonary atresia. The median follow-up in this work was 9.5 years. And so what did this model identify as independent predictors of death? Well, there were in fact 5, and these were older age at the time of CMR, so basically older patients, obesity, the type of Tetralogy of Fallot repair with RV to PA conduit patients generally doing worse, higher RV end systolic volume index, and lower biventricular global function index, which is a measurement performed on CMR and described previously. For those interested in understanding how powerful each of these factors were, I would read the paper for the individual hazard ratios, but the factor with the highest hazard ratio was the type of Tetralogy of Fallot repair, with patients having an RV to PA conduit repair having a hazard ratio of nearly 3 for the primary outcome, in comparison to standard Tetralogy of Fallot repair patients. Importantly, the authors compare the outcomes between the development group and the validation Toronto patients, and the concordance index was 0.8, suggesting that the validation set actually did validate the development set, further strengthening the validity of these findings. The authors basically then used this model to create a score based on the model, and the score was used to see if patients could be stratified into low or high-risk groups, and the details of the score, which incorporates some of the factors that I've already described, are described in detail in the paper, and there's really an excellent schematic of the risk score in Figure 2 of the paper, which includes the age at CMR, the kind of tetralogy repair, some echometrics, but the bottom line is that for this model, a cutoff score of 4 effectively discriminated between patients at low or high risk for death at 5, 10, and 15 years in both the development and validation cohorts. And using this score, 15-year survival was 95% in patients less than or equal to 4 on this model, whereas those who had scores over 4 had only 74% survival 15 years out. Importantly, this risk score calculator is available online, and the web address to the calculator is going to be in the show notes for those interested. In their discussion, the authors state, and I quote, "The increasing rates of morbidity and premature death in the growing population of adults with repaired Tetralogy of Fallot has motivated the development of risk stratification tools using invasive and non-invasive measures. However, these studies are often hindered by small sample size, lack of population diversity, short length of follow-up, paucity of major outcome events, and lack of model validation, all leading to limited generalizability. The use of a large cohort derived from 4 congenital heart centers in Europe and North America, followed for nearly a decade after detailed phenotyping at study entry, enabled us for the first time to derive and externally validate a mortality risk prediction model for repaired Tetralogy of Fallot. In addition, the external validation of low and high-risk strata to effectively discriminate risk of death provides a practical tool to identify high-risk patients with repaired Tetralogy of Fallot who require frequent surveillance and may benefit from targeted interventions. The authors review the importance of the concordance in results and findings in both the development and validation cohorts, suggesting that the model is broadly applicable to tetralogy patients who have been repaired. They suggest that the scores obtained in this model for any given patient could be used to help inform decisions regarding follow-up, and give an example of a patient with a low score with the chances of an untoward event very low given the very good negative predictive value of 99 to 100% of this tool, and they suggest that maybe follow-up could be less frequent in such a patient rather than the presently recommended every 2 to 3 year CMR recommendation for all tetralogy adult patients with no or mild disease. Consideration in patients who have low scores to stretch that, for example, to 5 years might make sense. In similar vein, patients who have high scores might require more frequent follow-up or even greater consideration for things like pulmonary valve replacement. In addition to the comments made already, the authors also make specific reference to the novel observation of an elevation in RV systolic volume indexed over 80 milliliters per meter squared as a risk factor, and how pulmonary valve replacement was associated with lower risk for adverse events, and they wonder if these data might help inform pulmonary valve replacement decisions. The authors go into the 5 different factors that were independently associated with the primary outcome, and make note of the fact that obesity is one that is potentially modifiable, and review how elevations in BMI can be associated with worse systolic and diastolic heart function. Therefore, a proactive approach to obesity in these patients is likely especially beneficial and worthwhile. In regards to study limitations, the authors mention how all patients had to have an MRI in this work, and how this would mean that patients who have pacemakers or ICDs before CMR were excluded. The authors speak of the need to still test this algorithm in other locales beyond the 4 centers in the indicator cohort study. They mention how they cannot tease out the impact of valve-sparing surgery for tetralogy and outcomes due to the way that this was studied. They speak also of how longer follow-up periods will improve the model's predictive power, and they wonder if machine learning-based models may improve upon this model, and wonder if imaging biomarkers like strain or fibrosis seen on T1 mapping or late gadolinium enhancement should be reviewed, and they similarly wonder if serum biomarkers or even genetic data or social determinants of health should be incorporated into these predictive models. And so they conclude, in this multi-center cohort study, we developed and externally validated a risk-scoring algorithm that effectively identified low and high-risk strata of all-cause death. These findings represent a step toward improved selection of high-risk adults with tetralogy of Fallot that is repaired, who may benefit from targeted intervention and/or closer monitoring. Well, this is an interesting paper, once more looking for that holy grail of congenital cardiology, namely identifying the at-risk tetralogy patient. This paper is looking for all-cause mortality and not sudden death as some of the other works we have reviewed here, but it is of great importance in that it may help us better understand who we should be more concerned about. Are these data enough to go to the website, plug in your patient's data, and come out with an accurate assessment of risk? I don't know. The authors themselves seem to suggest in one point that it is, but then in other points that further validation is needed. I think in the interest of time, it would make sense to proceed now to our conversation with one of the 2 senior authors of this work, Dr. Tal Geva. Tal Geva is the Cardiologist-in-Chief and Chairman of the Department of Cardiology at Boston Children's Hospital. He is a graduate of Sackler School of Medicine in Tel Aviv, Israel, followed by residency at the Chaim Sheba Medical Center in Tel HaShomer, Israel. He completed Cardiac Pathology Fellowship at Boston Children's Hospital, followed by Clinical Cardiology Fellowship at Texas Children's Hospital, Baylor College of Medicine. His major clinical and research interests focus on diagnostic imaging of congenital heart disease, including anatomic and functional assessment of complex malformations using echo and MRI. He established and developed the cardiac MRI program and was chief of the cardiac imaging division until assuming the current role he has as Cardiologist-in-Chief. His clinical practice focuses on management of patients with complex congenital heart disease as well as pediatric cardiac tumors, and his research has concentrated on the development of echo and cardiac MRI methods to define quantitative functional and morphometric predictors of course and outcome in native and postoperative congenital cardiac lesions. It is a delight to welcome my friend and colleague Tal to the podcast. Welcome, Dr. Geva, to Pediheart. I'm here now with Dr. Tal Geva of Boston Children's. Tal, thank you very much for making time to speak with us this week on the podcast.
It's a pleasure to be with you, Rob.
Thank you. Thank you very much, Tal. Same here. You know, Tal, for this work, one of the novel approaches that you and your co-investigators took was to validate the findings of the development cohort, and you used the Toronto group as a validation cohort. I'm certainly no expert in statistics, as anyone who's listened to this podcast knows, but I wonder, as someone who's not as familiar with these sorts of analyses, though the Toronto group are from a different location than the other three development cohorts, since they're also part of Indicator registry, are there any negatives of using an actual member of the Indicator study group as a validation cohort that are sort of already part of Indicator rather than, shall we say, a random group from another location? And in similar vein, given that there were differences between the development and validation cohorts, I wondered if it might have worked better to have just used sort of matched validation cases within Indicator rather than a specific center. And I was wondering how you made that decision.
Oh, absolutely. Thank you, Rob. There are two parts to this question, so I'll answer in two parts.
Sure.
It certainly would have been ideal to develop the risk prediction model utilizing all 1552 eligible indicator patients as opposed to the 1,200 that were left after segregating the Toronto group. But it's important to note that identifying another cohort that does not belong to Indicator would have been quite challenging. What we would need is a cohort with similarly detailed baseline phenotyping, sufficiently long follow-up period, having enough outcomes, and these requirements simply proved impractical at the time of study design. Yeah. So, having said that, it's most certainly our goal to further validate our model using cohorts from other parts of the country and abroad. And the second part of the question about randomly dividing the entire cohort in, let's say, 80-20 or 75-25 or something like this. In all the reason that we didn't choose that, and we most certainly had robust discussions about it, is because it would have elevate or increase the likelihood of having good results from the matching and the validation, because the groups, the development and validation codes would then be more similar to each other. When we chose Toronto, and we chose Toronto because of the sample size, so 21% of the total cohort, we are quite aware that the groups will have different characteristics, and that turned out to be the case. So the fact that the model worked well for a different cohort, different characteristic, different center, I think adds to the validation part.
Yeah, you guys made that point in the discussion. But thank you for clarifying that, Tal. I'm sorry. I know it's a kind of basic statistical question, but I figured I'd ask it. In the discussion of this work, you and your co-authors state that the model's similar outcomes in the development and the validation cohort mean that this model can likely be broadly applicable. And you sort of hinted at it just now in your last answer, but Is it your belief that this model scoring system is now adequately validated, that it could be used as a clinical tool? I mean, I noticed you even gave people the link to the tool itself. Or is it your belief that more validation is required prior to it being more broadly used? One of the things I wondered was, is it better for patients who score well versus those who have higher scores, or which, of course, is a worse case?
Right. Well, you're raising a very important question, Rob. It hinges on the phrase adequate. And to my knowledge, the development and external validation of this risk score are the most extensive currently available. More than 1,500 patients followed for a median of 10 years. Some of the patients had been followed for up to 20 years. So I would suggest that I would consider the validation as reasonably strong, but I would not state that that's it, we're done. Yeah. There's no room for further validation. There's no question in my mind that there needs to be further validation. My hope is that, the two large cohorts that I'm aware that are out there, one is the German Competency Network. They published in 2020 372 patients with 7 deaths. And the other one is Correlate, the study that Rachel Wald is leading out of Toronto. They have 720 patients with 13 deaths. I hope very much that it will be published soon. And these are the type of cohorts that could be used to further validate our findings. And I'm looking forward to it.
I'm sure you are. Thank you, Tal. So I guess you're saying maybe we shouldn't all go to that link other than to understand the tool better, but perhaps not to yet use it clinically just yet. Is that fair?
We are going to start using it. Okay. What we're going to do, at least my plan, is to incorporate it into our MRI reports. So, in fact, the reader would only have to select from a pull-down menu the type of repair. Everything else is integral to the report, and it would then display the risk score.
I see.
And just like any clinical tool, number one, I don't think any of us who take care of patients would use it out of context and would use it without taking into account a whole host of factors. Yeah. But it's just yet another tool that we can use, and I think that the more validation and more experience with the more it will be accepted or rejected. That's the scientific process.
Yes, for sure. And as you say, I mean, go find another study that has 1,500 tetralogy adults in it. Not very easy to find, for sure. Tal, in your discussion, you guys mentioned that AI approaches might actually improve upon the model or maybe develop a better or a different kind of model. And I'm wondering if you could explain in general terms how using that technique would potentially result in maybe a different data or a better model than the very robust multivariable model you've already presented in this work.
Yeah, this is a fascinating topic, Rob. So, in fact, our original design included 2 statistical arms. One, traditional statistics, so that's the multivariable Cox regression, and the other one, AI. And what turned out is that the AI model performed similarly to the traditional statistics. And in fact, in our first submission, the reviewers felt quite strongly that the paper is too complex to read, that it looks too much like a comparison between 2 analytical approaches as opposed to as opposed to development and validation of a new clinical tool. So they gave us a thumb down and suggested in pretty uncertain terms that we should choose one and go with it. Yes. So you see the results in the paper. We do have the AI model. It's amazing. The C index, the concordance index of the traditional was 0.84, and the C index of the AI was 0.83.
Okay.
It didn't, and what is also fascinating is that when you look at the individual parameters that got into each of these analytical arms, there was a substantial amount of overlap between them. Right. So the bottom line was that not having AI in this particular study didn't subtract anything. And my hypothesis as to why AI did not perform better is that this is not the kind of data set that AI shines in. In other words, AI shines in very large data sets that includes many millions of data elements.
Yeah.
I'm excited about using AI to analyze ECGs.
Yes.
And we have a paper that we hope will find a good home in repair Tetralogy of Fallot with very promising results. And keep in mind, doing an AI analysis on an ECG is something that can be done in all corners of the world.
Yes.
You don't need MRI for that.
Sure.
So these are some of my thoughts. The other exciting potential is to do MRI on the actual images, the raw images, something called radiomics. And not easy, but I very much like to see how that works.
Yeah.
In that respect, AI has a promise, and we'll see how that works.
Well, for those listeners to the podcast, I'm sure you remember that we had the first author of this work, Josh Mayorian, on the podcast just a couple of months ago, talking about his AI model looking at LV dimensions and function. And I don't know if you recall, Tal, but my center, Mount Sinai, was the validation cohort for that study. And actually, Sunny Duong, who works with us, is one of our up-and-coming researchers and has done a lot of collaborative work with Josh. Well, Tal, I can't thank you enough for speaking with us. I'm going to finish up with the last question. And I thought it was interesting, and I was wondering if you thought that the data in your work might actually help inform decisions regarding pulmonary valve replacement in the tetralogy patient. It seemed, for example, that in this work, the end systolic indexed volume was actually associated with poor outcomes, inversely. And this is a somewhat novel observation. Typically, we think about diastolic volumes in this disease. I'm wondering if you think these data may help inform these sorts of decisions regarding timing of PVR.
So, I think they will. I am very hopeful that the next or an upcoming scientific statement from the American Heart Association will use these new observations to come up with some new guidelines. For full disclosure, I'm part of this, and I think that we are overdue for some change the paradigm.
Yes.
And I also, as you know, the American College of Cardiology and American Heart Association writing group for guidelines for management of adults with congenital heart disease is just getting underway. And I suspect that by the time that they will sit down to look at guidelines for repair tetralogy, I hope that at least some of this will make it into the guidelines.
Yes, I imagine you're absolutely right in that regard. Well, Tal, I want to congratulate you, Dr. Mayorian, and all of your many co-investigators and multiple centers throughout the world. Really wonderful work. I think you're getting close to that holy grail of predicting the tetralogy patient outcomes. So congratulations, and thank you so much for taking time in a very busy week to speak with us this week.
Absolutely. My pleasure, Rob.
Thank you. Well, what can I possibly add to one of the most eminent experts worldwide on congenital heart disease and imaging in Dr. Geva? I think you will agree that he was, as usual, very clear and incisive in his thoughts, and I believe that it is very interesting to hear some of the details regarding how some of the methodology for this work was determined, allowing us to better understand the data we have reviewed this week. As I mentioned, I will try to include the link to the calculator in the show notes, and I would once more like to thank Dr. Geva, who was extraordinarily busy this week with both his clinical and administrative duties, as well as his many, many tasks in Portland, Oregon at the American Society of Echo meetings. I'm not really sure if I could have picked a worse week for him to have to come on the show amidst all his other responsibilities, but being the wonderful friend he is, he made time, and I am most appreciative to him for speaking with us this week on the podcast. To conclude this 301st episode of Pediheart Pediatric Cardiology today, we hear a wonderful recording from way back in 1959 of the love duet of Act 1 of Puccini's Madama Butterfly, and the two singers are two of the greatest singers in the history of opera, the great Spanish soprano Victoria de los Angeles and the great Swedish tenor Jussi Björling, singing as if their lives depended upon it, and what a beautiful sound they create together. I hope you enjoyed this Golden Age recording. Thank you so much for joining me for this 301st episode, and thanks once again to Dr. Geva. I hope all have a good week ahead.
Io t'ogernita ti serro palpitante, sei mia. Sì, per la vita. Vieni, vieni, via dal